This is a visual roadmap for understanding acute lymphocytic leukemia, beginning with the epidemiology represented by two distinct peaks in incidence. A young child wearing a party hat signifies the primary peak at 4 years of age, while an older hiker represents the second peak, typically seen around 40 years of age. This demographic overview transitions into the clinical presentation, where a central figure illustrates the systemic impact of the disease. The figure highlights bone pain through throbbing auras around the joints and indicates an enlarged spleen and nervous system complications caused by lymphoblast infiltration. Furthermore, the laboratory findings are depicted as elevated levels of uric acid and lactate dehydrogenase, while a gauge shows that 60% of patients will present with an increased white blood cell count. Moving from symptoms to laboratory diagnosis, the image utilizes a microscope section to detail specific cellular markers. Terminal deoxynucleotidal transferase, commonly known as TDT, is shown as a positive marker for immature blasts but remains negative in mature cells. The presence of T cell lineage is identified through a positive acid phosphatase test, while the characteristic periodic acid shift block positivity reveals the presence of vacuoles within the cells. These diagnostic markers naturally lead into the morphological classification systems. The French-American-British classification, or FAEP, divides the disease into three categories, where L1 consists of uniform small blasts, primarily in children, L2 involves variable large blasts in adults, and the rare L3 type features large blasts containing prominent vacuoles. The complexity of the disease is further refined through the World Health Organization classification, which focuses on cell lineage and genetic mutations. B-cell acute lymphocytic leukemia is described as the more common type in children and is associated with a good prognosis, identified by the presence of CD19 and CD20 surface markers. In contrast, the T-cell type is shown to primarily affect boys and carries a poorer prognosis, characterized by CD1, CD2 E-rosettes, and TDT positivity. This section also highlights the Burkitt type, which corresponds to the L3 morphology, and is driven by a translocation between chromosomes 8 and 14 that activates the C-MyC oncogene. These genetic and lineage factors are crucial because they directly influence the prognosis, where female patients, those with lower white blood cell counts, and those with L1 or B-cell types generally face better clinical outcomes. The final portion of the mnemonic illustrates the structured approach to treatment, visualized as a 4-phase hematology marathon. The first phase, induction, aims to return white blood cell counts to normal levels and reduce bone marrow blasts to less than 5%. For patients carrying the Philadelphia chromosome translocation between chromosomes 9 and 22, an ABL kinase inhibitor is added to the standard CVD regimen consisting of cyclophosphamide, vincristine, adriamycin, and dexamethasone. Following induction, the consolidation and intensification phase uses more intense chemotherapy to further reduce the leukemic cell burden. The journey continues through the maintenance phase to keep the patient in complete remission for as long as possible, eventually concluding with the reinforcement phase, which represents the ultimate goal of achieving a total cure.